Welcome to the Screening Brief, Intervention and Referral to Treatment, Coding and Reimbursement Guide Updates webinar. My name is Vanessa, and I will be your operator for today. At this time, all participants are in a listen-only mode, but later we will have time for questions. I will now turn the call over to your host, Julie Schmelzer.
Thank you, Vanessa, and good afternoon, everyone. My name is Julie Schmelzer, Project Specialist at Metastar, and I would like to welcome you to today's webinar, Screening, Brief Intervention, and Referral to Treatment, SBIRT Coding and Reimbursement Guide, presented by the Lake Superior Quality Innovation Network, or LSQIN. The LSQIN is comprised of three organizations, MPRO in Michigan, Stratus Health in Minnesota, and Metastar in Wisconsin, to support the Centers for Medicare and Medicaid Services priorities for health care quality improvement. This session is being recorded and will be available in approximately 2 weeks on the LSQIN website YouTube channel. At the close of the webinar, we will provide you with several evaluation questions. Please complete the evaluation so LSQIN can continue to provide events that are useful to you in the important work that you do. Today, we are pleased to have an opportunity to learn more about the recently updated Screening, Brief Intervention, and Referral to Treatment, or SBIRT Billing and Coding Guide. Metastar collaborated with coding expert Jen Kors to update the SBIRT Guide, and we are very fortunate to have her with us today. Jen is the Business Office Manager at GI Associates in Wausau, Wisconsin. She is a certified professional coder and a certified professional medical auditor through the American Academy of Professional Coders and the National Alliance of Medical Auditing Specialists. Jen possesses a wealth of knowledge across multiple specialties and has years of experience in coding, billing, auditing, revenue cycle, and more. As the former Director of Educational Strategies for the Wisconsin Medical Society, she provided coding and reimbursement education and resources to physicians, clinics, and coders across the state of Wisconsin. Jen is a trusted resource for many clinics, physicians, and coders across the region. At this time, it is my pleasure to turn the presentation over to Jen Kors.
Thank you so much, Julie, and it's my pleasure to be here today, and that's actually my birthday, so happy birthday to me doing a webinar for this great group, the LSQIN and Metastar. So today we're going to talk about Screening, Brief Intervention, and Referral to Treatment, or SBIRT, also known as SBI before the RT was added later. So today, SBIRT in history, we are going to talk about how this became established and why we did this update to the manual and why it's important for primary care offices and other providers to do these services for patients. So first in history, screening, brief intervention, and referral to treatment is an evidence-based practice. It's used to identify, reduce, and prevent abuse and dependence on alcohol and other substances that can become addictive. SBIRT services have evolved over the years and have gained popularity because of the successful outcomes for patients, screening and identifying the abuse and dependence, intervening for those patients, and then referring them to treatment if needed. SBIRT has demonstrated cost and health savings and has really grabbed the attention of federal agencies such as SAMHSA or the VA and some other areas such as CMS and some other managed care providers and other major medical associations like the AMA. Now, these agencies have recommended the routine use of these services and then subsequently supported payment or reimbursement for the healthcare providers who perform them. For Wisconsin, there was a federal and state push for providing preventive services, as well as legislation subsequently requiring Medicare, Medicaid, and even some commercial payers to pay for them. And because of the Medicaid and Badger Care Plus rate reform project in Wisconsin in 2009-2011, Medicaid in Wisconsin has expanded the SBIRT benefit for all patients for a wide range of provider types. The Affordable Care Act set in motion the requirements for Medicare and commercial insurance to cover preventive services with little to no out-of-pocket cost to the patient. You may be familiar with the requirements for routine or preventive coverage for mammograms or colonoscopy, but people don't realize that there are several benefits that are listed in the USPSTF list for grade A and B services that should be covered at little to no cost to the patient, and SBIRT services are on that list. So when we're talking about SBIRT, we're talking about three distinct parts: the screening piece, and the brief intervention and referral to treatment. The screening is the proactive service used to identify those individuals who may have that condition before obvious manifestations occur. So before they come in with problems or complaints, we screen to identify if they might be in that harm's way. So, for example, a brief screening for alcohol or substance abuse could include a short questionnaire with questions relating to social activities, drinking, and drug use. If the physician or nurse practitioner or physician assistant or other qualified healthcare professional determines that this is an area of risk for this particular patient, then maybe a full screening would be administered to more definitively categorize that patient's substance use and abuse. The full assessments are indicated for patients with positive brief screenings, or really for patients with signs, symptoms, social history, past family social, or medical conditions that suggest risky or problematic behavior that might lead to drinking or drug use and abuse. Now, screening is based on the patient's responses as well as the observations by the provider. So the physician or the PA or the NP could be having a conversation with that patient, and the patient may be avoiding the answers to the questions. And those mannerisms by the patient or the hesitation to complete those assessments may also drive a brief intervention for the patient from the provider, because they may look to that as that patient needs the attention, even though they didn't answer the questions. They avoided answering the questions. So that might indicate the need for further intervention as well. So it's a subjective screening from the patient giving answers, but it's also an objective based on the mannerisms and the provider's view of what's going on with that patient. And then there's the brief intervention and the referral to treatment, which we'll get into in a little bit. So to screen beyond the first few questions asking basic history, there's different questionnaires that offices use to determine if there is a substance use, abuse, or dependence, or an alcohol use, abuse, or dependence. The audit, the AUDIT test, or the Alcohol Use Disorders Identification Test, is one of the most popular tests in the area of primary care physician offices, because it's very straightforward in the questions. It's simple, and it's not lengthy. I think it's maybe 8 or 10 questions. It's reliable for use to determine that level of alcohol use. It's based on a scoring mechanism, so it helps the provider understand if there is a use or a harmful or hazardous drinking. Some of the questions on those tests include: how often do you drink or have a drink containing alcohol? How often do you have 6 or more drinks on one occasion? And the answers are subjective: never, less than a month, monthly, weekly, daily. It sort of gives you a scoring mechanism based on the frequency of the answer of your question. And some other question: have you or someone else been injured as a result of your drinking? Has a relative or friend or doctor been concerned about your drinking in the past? So it really dives into more than, do you drink alcohol and how much do you drink? So it gets more of a frequency basis so the provider can assess whether or not an intervention is appropriate. The DAST, or the Drug Abuse Screening Test, the ASSIST, the CRAFT, and the POSIT tests are all different screening mechanisms and assessments in place to really identify and place that patient on a continuum of use. Is it social use, or is it problematic abuse, or is it a dependence? And then it suggests whether no intervention, a brief intervention, maybe some treatment or a referral to treatment is appropriate based on the answers of these screening tests. If you have not heard of the CRAFT or the POSIT, those are more used in the pediatric area for adolescents, teens and adolescents, to determine their use, abuse, or dependence on alcohol or substances. So once the patient has done the screening assessment and a brief intervention is needed, we need to understand what that brief intervention all entails. So brief interventions they're really designed to motivate patients to change their behavior and prevent the progression of that use. It's not meant to slap your hand or say that you're doing anything wrong. It's saying, you know, your alcohol use may become problematic, or if you got injured the last time, say they fell, and you say maybe you should watch what you're doing and watch your alcohol intake because it could lead to other problems in the future. You could hurt yourself more, or you could hurt someone else. It's really a discussion of the risks of alcohol abuse and health risks that are associated with continued or increased alcohol or drug abuse or dependence. It's also to identify the impact on the patient's overall health. So if a patient has diabetes or other chronic illnesses, it may lead to symptoms that they're experiencing, such as gastritis or heartburn, stomach pains. It might be leading to the headaches, things that patients don't often connect with their alcohol use or dependence. Brief interventions are typically used as a management strategy for patients with risky or problem drinking or drug use who are not dependent. Just talking about it with your physician gets you aware of the risks involved, and these interactions are intended to induce a change in the health-related behavior. So it's not acknowledging it and shoving it under the rug. It's acknowledging the use and intervening on what might become problematic behavior in the future. Often 1 to 3 follow-up contacts are provided to assess and promote progress and to evaluate the need for additional services. So one conversation may be enough for one patient, but a follow-up might be needed, and that's based on the provider's interview with that patient for that examination and that assessment. So if the patient needs something more than just a brief intervention, we may end up referring them somewhere for treatment, to a mental health facility or rehab center, or somewhere that they can get their use and abuse or dependence under control. Patients who are identified as dependent on a substance are typically referred to the treatment experts for that really definitive, in-depth assessment and then that treatment. The screening and brief intervention results and the documentation from that screening test and the intervention should be sent to that referring office, so then they can understand, you know, the purpose behind the referral, and they can get a baseline of why that patient is there and why they're being seen. Then that behavioral health specialist will determine if the patient needs brief or extended treatment. For example, a brief treatment for alcohol dependence could be several planned sessions with interactions with one person, or it could be like a group therapy session to help the patient quit or cut down and reduce the negative impacts of the substance use on their life. Brief treatment is typically provided with patients with likely dependence who cannot or will not obtain the conventional treatment on their own. So they need that support from that physician or that care provider to help them change their lifestyles. Brief treatments may also be provided to patients who are receiving medication treatment to assist with alcohol, stopping the alcohol use or the opioid dependence or whatever the substance might be. And those providers can then evaluate the medications involved and the treatment for that patient and see if it's sufficient or if they need to make modifications. Handling the referral process properly and ensuring that that patient receives the necessary care coordination and follow-up is critical to that treatment process and to facilitating and maintaining recovery. So it's very important that offices don't just screen and then throw the screening results in the chart. It needs to go beyond that. So essentially we can't drop the ball. The patients who need treatment often need a nudge to go to treatment and get help. So 1 to 3 calls or some follow-up care is needed to get the patients the help they need. And communicating with those referring offices is really beneficial as well. So now that we have an overview of what SBIRT, or Screening, Brief Intervention, and Referral to Treatment, is really all about, we need to know how to incorporate the services into the workflow, the daily office service. The reimbursement for SBIRT and many preventive or wellness services is often limited to primary care setting or primary care doctors, but there's been many changes over the years as to what that means. If you are a specialist and you are essentially the primary source for that patient's care, if that's where they go, and the specialist is an MD, they can certainly provide SBIRT services so long as the patient doesn't have a primary care physician that's also providing those services. So it can be incorporated into specialty physician offices as well as primary care settings. It's a little more difficult, but it is possible. Now, a physician can provide the services independently and be reimbursed. One-on-one, physician provide the screening and the assessments, but in the real world, we know that our physicians have precious minutes in their days, and the clinics run tight, and we utilize ancillary staff such as health educators or medical assistants or scribes for administrative and basic clinical tasks. So the use of these ancillary staff or the clinical staff has become integral to run a clinic effectively and efficiently. Specialty clinics who are primary care source can also use these ancillary staff and receive the benefits for those patients. For AMA, or the American Medical Association, and Medicare, uniformity in the terminology has aligned with coding definitions and coverage policy. So when we talk about an ancillary staff member or a clinical staff member performing a service for screening for alcohol or substance abuse and dependence, we're talking about the same people, whereas it used to be ancillary staff versus clinical staff versus medical health professionals, and they've more or less aligned the terminology. So what that means is physicians, the MDs and DOs, can provide the services along with an other qualified healthcare professional, or a QHP in this case. Now, a QHP is widely used throughout the AMA CPT professional coding manual. If you are professional biller, you are familiar with the CPT manual and the use of physician or other qualified healthcare professional preceding the E&M codes. And it's often used to just include nurse practitioners and physician assistants and other providers who are now providing services and reporting and being reimbursed for them. So that QHP is, by AMA definition, is an individual who is qualified by education, training, licensure, regulation, and facility privileging when it's needed, who performs that professional service within his or her scope of practice, of course, and then independently reports that service. So a way I like to think of it is a QHP is somebody with an NPI. They have their own national provider identifier, so they're performing a service and they're able to bill directly for it under their own NPI. So that includes physician assistants, nurse practitioners, etc. Medicare considers other qualified healthcare professionals such as a clinical nurse specialist, a clinical psychologist, a clinical social worker. All of those QHPs are eligible for reimbursement for SBIRT services as well. Now, you have to keep in mind that the QHPs are distinct from clinical staff. A clinical staff member or an ancillary service member is that person who works under the supervision of the physician or the QHP. So it's the medical assistant, it's the CNAs, it's the health educators, and they're allowed by their training and schooling and law and regulation to perform or assist the performance of the services, but they don't individually report for that professional service. So they don't, the way I like to think of it is they don't have an NPI and they don't perform the service alone. They perform the service under the direction of someone with an NPI. Health educators and medical assistants often assist physicians and QHPs involved in tasks with SBIRT, such as handing out the assessments, taking the vital signs for a patient, and maybe rooming the patient if they're there for a clinic visit. They must perform those services, of course, under the supervision of a professional that is a NP, PA, or an MD, and that means that that physician or qualified health professional must be available in the same office suite and has decided that, yes, this patient should have this service. So it's part of that plan of care as outlined by that physician or QHP. And of course, there's all kinds of resources on what direct supervision, general supervision means, and that's all in the Medicare manuals. And I believe there's a link at the end of this slide to the CMS guides as to where you can find that information. For a complete understanding of that supervision and signature requirements, it really depends on the state you're in as whether or not a signature or a co-signature is required as well. So you want to make sure that if you have ancillary staff documenting on behalf of a provider, you want to be sure that the documentation and the signature requirements are met as well. Okay. So when we talk about the service for the procedure coding for SBIRT, we talk about what's included in a code. Where did this come from? So we talk about the MA or the health educator handing out the assessment and taking vital signs, and then the physician interpreting those results and making recommendations. So we understand what goes into it, but what constitutes supported documentation in order to bill for it and then get reimbursed for it. So there's some background with these SBIRT codes. As they started over 10 years ago is when these SBIRT codes first came to light, and they were actually referred to as SBI at that point. Actually, November 2007, the American Medical Association released new CPT codes for the SBIRT services for implementation on January 1st, 2008. When the new codes are introduced, it's a standard that significant background be provided in the decision process that results in the adoption of the new codes. So where did it come from? And that is all in part of providers doing these services and documenting for the services and throwing ideas at the AMA saying, hey, we provide these services and it's helping and it's cost savings, but we should be paid for these screening and brief intervention services. So in reference to the creation of the codes, the AMA said that a screening and brief intervention, or the SBI at that time, describes a different type of patient-physician interaction. It requires significant amount of time and additional acquired skills to deliver beyond that required for provision of general advice. So it's beyond your typical interaction. The SBI techniques are discrete, clearly distinguishable clinical procedures that are effective in identifying problematic alcohol or substance use. So the importance of screening and intervening for those patients who are not necessarily identified as abusers, there's a list of components that required to build the code. So what they're saying is the procedure code is represented by the components listed here. So a standardized screening tool should be used, such as the audit or the DAST. Of course, the AMA or CMS doesn't recommend or cannot make recommendations in this case on a specific test as long as it's a standard test that is used for the specific assessment. The patient should receive feedback concerning the screening results, so you're not just handing out the assessment and filing it away in the chart. There should be discussion of negative consequences that have occurred and the overall severity of the problem. Action should include motivating the patient towards behavioral change. A joint decision-making process regarding alcohol or drug use should be used, and plans for follow-up are discussed together and agreed to. So this is a physician, patient, or QHP patient conversation that's taking place based on the results of that screening test. If you are using the SBIRT services in your electronic health record, you may consider building a template that includes specific elements of documentation. There's not requirements or a template, but it must include specific elements to support and satisfy regulatory requirements. Specifically, the reason for the encounter. That's pretty basic. If you look at any office note for any reason, the first thing on that office note or any documentation should be, why is that patient there? Why are you seeing the patient today? And it could be for preventive health services and alcohol assessment or whatever it might be. It should be clear and easily understood by whomever grabs that encounter. That current history, maybe progress, responses to treatment, what's the patient up to, that subjective history. Then there's the past medical history, the family history, social history. It's pretty basic, and it could be relevant and identify health risk factors. If there's social history going on, if they're identified in their social history as heavy drinkers or recreational drug use, if they have a family history of alcoholism, it might identify health risk factors. A brief physical examination, vital signs and what have you. The assessment, including the screening tool results, even a copy of that result in the medical record is good support for the service that you're reporting. And the clinical impression and diagnosis, plan of care, really specifically outlining any referral that's needed, and treatment and recommendations, and any recommended follow-up calls that the RNs or the MAs are supposed to make when following up with this patient. And then it is a time-based code. So the time spent face-to-face with a patient, and it could be either start or stop times or total time in minutes, is needed in order to bill accurately for the codes. Now the AMA defines a unit of time as when the midpoint has passed. So for example, to report a service that is time-based, which these are, and it's 15 minutes, at least 8 minutes of face-to-face time with the patient must be documented to support that CPT code for billing purposes. So it needs to be more than just handing out an examination and putting in the chart. It needs to be something that is beyond that. It needs to be that conversation and that plan. In addition to documenting the service provided, they're required to keep that test in order to bill for that full screening and brief intervention that took place based on the results of the test. Now, the providers using electronic versions of the test should have a way to save an electronic copy of that as well. I don't know if you could save it as a PDF and have it scanned into the medical record, or if it just interfaces into your EHR. There's all different options, but a copy of that test with the assessment results should be kept. So the codes, the CPT codes and the HCPCS codes for screening, brief intervention, and referral to treatment, some of them are listed here. The CPT codes 99408 and 409 are representative of that audit or that GAST test that's administered. And you'll see that it says alcohol and or substance abuse structured screening and brief intervention services 15 to 30 minutes. So when we think about that unit of time per the AMA, a unit of time is when the midpoint has passed. So if the patient has done this service and you've talked to the patient for a minimum of 8 minutes, you can report the 99408, even though it says 15 minutes. 99409 would be greater than 30 minutes, and that would be having a documentation supporting that conversation that took place directly related to that brief intervention or the intervention and lifestyle changes that the patient is going to make. Medicare has followed the G codes or the HCPCS codes for the same services. It's the same idea. It's just different codes because one set is CPT codes and the other set is HCPCS codes. Wisconsin Medicaid follows the idea of the HCPCS codes but has designed and designated their own H codes. So the service descriptors reflect what we just described, that screening, brief intervention, and referral to treatment. The screening and brief intervention with the test and exam is listed here. Now, if you do just a screening test and the screening results are that no intervention is needed and really you don't need to do anything beyond that initial screening, there's another procedure or service code that can be used, and that's G0442, and that's that annual alcohol screening and assessment with no intervention performed after that. And that is another HCPCS code that's reimbursable not only by Medicare, but many commercial payers consider reimbursement for that service as well. So that is the CPT and the HCPCS codes for the procedures. So we have to include a diagnosis code with those screening exams, even if there isn't a result from that screening, such as alcohol use, abuse, or dependence. We need to include a screening code. And most insurance companies will take a peek at that Z code or that screening code and determine that is how they will process that benefit. They'll say, oh, it's a Z code attached to this service, and it's an accounter for screening, so that's what I'm going to do. I'm going to apply it to the screening benefits. So that helps with your claims processing as well. And in this case, we use the ICD10 CM codes for screening for other mental and behavioral disorders, the Z13.39. Other facilities have used both the Z13.30 or Z13.9, depending on the payer policy and the situation. Now, if you have a reason that you're screening beyond, you can include that as additional diagnoses. Say if you have someone who is suffering from depression or they have a family history of alcoholism, you can certainly use those codes as additional ICD-10 codes to describe the services. ICD-10 has specific Chapter 5 guidelines for the coding and reporting that for Chapter 5, mental and behavioral health disorders due to psychoactive substance use. There's specific hierarchy to use. If your coders have identified that there's use, abuse, and dependence documented in the record, then they would use the dependence codes because you cannot have dependence without abuse or use. So it's sort of that hierarchy. You wouldn't code all three. You would code just the most severe according to those Chapter 5 guidelines. And those Chapter 5 and all ICD-10 CM diagnosis coding guidelines are available on the Center for Disease Control website, the CDC website, for free. So that's a nice little tool, nice little PDF download of those guidelines if you can't get everyone an ICD-10 book or if it's not captured, nicely in your coding software. Some examples for ICD-10 coding. The diagnosis of problematic use, abuse, or dependence of the substance is clearly documented. We love our very specific documentation. If we're a coder and auditor, we like it black and white. We don't like gray. That's why we love E&M. Problematic use is identified when the patient has other medical problems, such as mood or neurocognitive disorders, that are induced by that use of that substance. So if it's identified as the patient having a use or abuse problem and other things going on, then the diagnosis codes really help tell that story. So for example, if a patient is identified as having an alcohol-induced depression without identified alcohol abuse or dependence, we code it as F10.94, alcohol use unspecified with alcohol-induced mood disorder. If a patient is identified as having a moderate alcohol use disorder, then we say that moderate is dependence per the guidelines and the ICD10 index. It points us to F10.20, alcohol dependence uncomplicated. So the documentation of the severity of the illness and the related disorders with the use or dependence will also drive the ICD-10 code selection. And that section is pretty wide. There's a lot of different substances and different disorders that can be coupled together to make a very specific ICD-10 code. So when we talk about reimbursement, so really that's what we want to worry about, right? Is we've cared for the patient and we've took the time out of our day as a provider. We've done all this documentation, so now we should probably get paid for it or reimbursed in a way that we can continue to incorporate these services into our practice and get a little reimbursement on the backside. So reimbursement is complex and confusing, and some payers use RVUs or relative value units. Some payers use a straight fee schedule. Some do a specific multiplier. So to understand what's going on in this slide, I'll explain just a little bit of reimbursement. So there's three key calculation factors, I should say: payment methodology, relative value, and conversion. So the payment methodology will guide you to the appropriate relative values. The most common methodology is the resource-based relative value scale, or the RVRVS. In addition to Medicare, many commercial payers and HMOs and managed care organizations use it to calculate the reimbursement rates. The RVRVS assigns procedures performed by a physician or a QHP a specific value, or RVU, that's then adjusted by geographic region. So the value of a service will probably be more in a downtown Milwaukee area than a rural rural town, I should say, in Wisconsin. This value is multiplied by a fixed conversion factor, which comes out every year in the Medicare Physician Fee Schedule Final Rule. It changes annually. It's used to determine the amount of payment. So it's that value multiplied by that conversion factor with a geographic calculation that gives you that value or that payment amount. And that is what we see on the approximate Medicare allowed amount for physicians for G0396. We can see that the RVU is 1.01, so multiplied times the conversion factor for the year gives us an approximate value of $36.35. So that's what Medicare would reimburse for that service should a physician perform, document, and report the service. Or if it's done under the direct supervision of a physician by that clinical staff and then subsequently reviewed with the physician and documented, then it pays that as well. If it's done by a QHP, then it's reimbursed a little bit less by Medicare Part B because that is it is reimbursed less, 15% less actually, for the QHPs or non-physicians. The Medicaid fee schedule is based off of the RVU file, but there's a little bit different calculation. and that's available on the Forward Health website. And you can get all of the reimbursements downloaded in a very complex looking document, or you can do their interactive fee schedule search and find the values for services based on CPT code. Commercial payers generally go off of an RVU or a contract rate or a multiplier of Medicare to determine it. So that would be based off of your local contracts and coverage policies as to what a Blue Cross Blue Shield or Humana or any of those other commercial payers might reimburse for the services. So now that we've understood we can perform the service, we can document the service, bill for it, and get paid for the service, there is one little caveat for specifically for Wisconsin. Forward Health, Wisconsin Medicaid, requires eligible providers, which would be the physicians, the nurse practitioners, and physician assistants, or those QHPs, to undergo training approved by the Department of Health and Human Services. So you should contact that office, and that email is listed there. It's at dhs.sbirt@wisconsin.gov for more information about the required training or to find out if they can be exempted from the training requirements. Some providers of mental health services or behavioral health services are exempt from those training requirements, but it's very important that you understand if your providers need to take this very short training to become an eligible provider of the SBIRT services for Wisconsin Medicaid recipients. So some frequently asked questions that we receive based on the screening, brief intervention, and referral to treatment services. Number one, is there a specific form that physicians are required to use to administer the screening tests? And the answer is no. There is not a specific form that's required from any payer, including Medicare and Medicaid, but all of them agree that an evidence-based screening tool should be used, such as the audit or the DAST or any of the other evidence-based tests listed earlier in the presentation. Number two, can a health educator or nurse administer the screening test under physician direction and bill for it? Yes, so long as the direct supervision requirements are met. The results of the screening test must be incorporated into the plan of care determined by the physician or that QHP. So can you bill for this? Yes, as long as that physician has been providing the direct supervision and performing that documentation of those results and that conversation that took place with the patient, you can bill for the SBIRT services under that physician or QHP, even though the assessment was actually handed out by the health educator or nurse. Number three, does insurance cover SBIRT services? Yes. So earlier we talked about the Affordable Care Act and the United States Preventive Services Task Force. And since the ACA, there are mandates in place that require insurance to cover services identified as a grade A or B service on the USPSTF Task Force recommendations. So the USPSTF recommends screening for unhealthy alcohol use in a primary care setting in adults 18 years or older, including pregnant women, and providing persons engaged in risky or hazardous drinking with brief behavioral counseling interventions to reduce that unhealthy alcohol use. It's the same as the screening and brief intervention. It's just elaborated a little bit with that USPSTF, so it's perfectly represented here. Unhealthy alcohol use in adolescents and adults, screening and behavioral counseling interventions are a grade B USPSTF service. This means that it is required to be covered by insurance with little to no out-of-pocket to the patient. I believe the deductibles are waived, but there might be some co-insurance depending. Now, if the commercial payers deny these claims, it could be very due to the unfamiliarity of the fact that the SBIRT services are Grade B USPSTF recommendations. Now, if this is the case, supporting documentation should be submitted with the claim for reconsideration. So you might want to go right out to the USPSTF website and print that out saying it is a Grade B service and the Affordable Care Act requires coverage. Now, some payers may have policies that may be useful to reference if there's a specific problem with reimbursement. Sometimes the policy might have a specific diagnosis that has to be used as a primary diagnosis in order to have coverage considered, but that would be all payer specific. Number 4, can I perform SBIRT as a telehealth service? Yes. So long as the telehealth service requirements and documentation are met and the SBIRT services criteria is met and documented, the service of SBIRT can be performed as a telehealth service. And just a little informational bit, if you're looking in your CPT books and you're wondering if something can be considered as a telehealth service, most of the CPT books identify it with some little asterisk or a star and indicating that it can be listed as telehealth. Number 5, can I bill for an evaluation and management service, or an E&M, in addition to the SBIRT services when they are performed in the same day? And the answer is yes, for that problem visit, as long as the E&M is that problem-oriented visit and it's you're not billing it as a screening service. You're talking about and addressing a problem above and beyond or significantly different than the screening service that you're providing. Any E&M services reported on the same day must be distinct and reported with that modifier 25 according to the AMA CPT manual. And time spent providing the services may not be used as a basis for the E&M code selection. So if you spent 30 minutes talking about the brief intervention and scheduling follow-ups with the patient, that time spent goes with the SBIRT service, not with the E&M service that you're reporting. So it can be done, but documentation needs to be separate and distinct. And number 6, is there special training needed to perform SBIRT services? Well, we did talk about Wisconsin Medicaid having that special training requirements through DHS. So that is the only specialized training that I am aware of. There's not requirements for Medicare, and there's not requirements for commercial health insurance at this time. Providers are required to maintain documentation that they are practicing within the scope of practice. So if you're an MD, you have to keep your license on file, but there's nothing above and beyond that's required for the SBIRT services apart from Medicaid. So there's some useful resources in the next 2 slides that
Again, you appear to be breaking up. Sorry, could you give me a few more words to see if the issue has cleared itself up?
The last 2 slides, 19 and 20, have useful resources.
I'm sorry, you know what? You do definitely seem to be breaking up quite audibly. The only thing I can suggest is that you drop and I reconnect you. Can we do that real quick?
Yes.
I'm sorry, everyone. Okay, please stand by, everyone. We'll resolve this technical issue. Thank you for standing by. Jen has rejoined us.
Hello. Gotta love technology, of course. It's probably that crazy winter weather that we're having in January, I should say, or lack thereof weather. So useful resources on slides 19 really help identify where all of this information came from in both the manual and in the presentation. The CMS has fact sheets regarding SBIRT services. The link is available there for both those and the telehealth services in case you are worrying about or wanting to incorporate those services as telehealth. Then there's the SAMHSA. It's really informational manual on SBIRT services, the history and where it's going and what to do in the future. Forward Health Portal and Wisconsin Medicaid, along with the links for that, the publications for the training are available here. The CDC, the ICD10 Guidelines link is available. And then, of course, if you have those commercial payers that are bucking reimbursement, you can certainly use the USPSTF or the US Preventive Service Task Force.org website to identify that it is a Grade B service. So that concludes today's presentation. My contact information is available as well as the lsqin.org website. So if there's any questions, we can certainly take those at this time.
Thank you.
Go ahead, Vanessa. Sorry.
Oh, no, thanks. Just wanted to let everyone know that you can submit your question using the chat box on the web platform, or you may ask a live question. To queue up with a live question, you can press star, then 1.
And Jen, this is Mia. We did have one question come in on the chat box. Mary Beth Alvarez asked, what is the difference between Z13.30 and Z13.39?
I assume she's referring to the ICD-10 codes, and you gotta love ICD-10 and how there's always that one specific other specified and unspecified. And the encounter for screening examination for other mental health and behavioral disorders is really the diagnosis code that is specified. You're looking for that other mental health and behavioral disorder. So you're looking for the substance use, abuse, and dependence. Whereas the Z13.30 is an unspecified. So you're looking for something, but it's not clearly defined. It's really the difference between an other specified and an unspecified diagnosis code.
Pardon me, I do have a phone question. Is it okay for me to take it?
Sure.
All right, looks like we have a question from Kurt and Andrew. Please go ahead. Your line is open.
Great, thank you. Thanks, Jen, for the presentation. So we are looking at different areas where we could potentially implement SBIRT, and one question was around the place of service. It's clear that it can be billed in place of service clinic or primary care settings. What about on an inpatient medical unit in a hospital, and what about in an emergency department?
So far, when I look at the bundling as to whether the service can be performed in conjunction with like a subsequent hospital visit or an inpatient consultation, it is not considered mutually exclusive or bundled. So just like it would be not mutually exclusive or bundled with an office visit. So place of service specific, I haven't seen any restrictions on that, and it's not bundled. So if you can incorporate it into your workflow, I would say that it would be reimbursed.
Excellent. One other question then regarding the elements for coding for SBIRT. I noted that it includes a physical examination. Obviously, a behavioral health therapist or health educator isn't going to be performing that physical examination. It would be inappropriate. So in primary care, the primary care physician is, or his or her nurse is part of that. How does that get captured in that note then for billing for SBIRT?
When the health educator or the nurse takes those vital signs and documents it, that is also considered part of it's considered enough of a hands-on physical examination to capture that piece. It's basically proving that the patient is in the room. And I know that the physical examination component has been questioned because you cannot perform that as a telehealth service. So I think it would be just what's medically necessary. I don't think there's a physical exam necessary, like you indicate, by the provider.
Okay, so just one clarifying piece. So then if we had health educators or therapists that were QHPs in primary care doing the SBIRT work, but it was an MA that roomed the patient that got the set of vitals, would that QHP be able to pull the MA's data into their note in order to have that qualify as an element?
Absolutely.
Okay, thank you.
You're welcome.
Thank you. To confirm, I don't have any further phone questions at this time, but it's star then one if you'd like to queue up over the phone. Do we have any more web questions?
This is Mia. There was a question about the physical exam if done by telehealth entered in the chat box, but I believe you already answered that, Jen.
Yes, and I think as we gain more information on telehealth services and more services become virtual, I think the physical exam component that's required for a lot of our services is going to drop off because it's not necessary. It's going along with the not medically necessary service. So again, the physical exam component is really geared towards those vital signs gathered by the MA or the person that's doing the rooming of that patient. As far as anything more, it would have to be, justified and medically necessary, which of course cannot be done via telehealth.
Great. Thanks so much, Jen. Since we're at just about the top of the hour, we will conclude the webinar today. I really want to thank you a lot for speaking with us, Jen, and offering your expertise. The recorded webinar will be available, as I said, in approximately 2 weeks on the LSQIN YouTube channel, which is www.lsqin.org. And again, thank you for sharing this valuable information today, and thank you to everyone for joining the webinar. Have a great afternoon.
Thank you.
And thank you, presenters. And thank you, ladies and gentlemen. This concludes our webinar. We thank you for participating, and you may now disconnect.